Okay. Were there any questions off the advanced organizer? And I do apologize, the cycle of violence that I was talking about is the picture on page 340. I think that might not be assigned in your book, but I do want you, or assigned in your readings, but I do want you to take a look at that particular chart. There's information in that chapter about intimate partner violence as well as child abuse, but we do not cover child abuse in this course. The child abuse is covered in pediatrics. Are there any questions over the advanced organizer? And we'll take a look at the cycle of violence in a little bit more detail, but in general, does it make sense? If you're looking at page 340, you have tension building, so the abuser's kind of edgy and maybe verbally abusive. The victim feels like they're walking on eggshells. Then you have the serious battering phase where there's a serious battering incident that takes place and the tension becomes unbearable. Sometimes the victim will even, push things a little bit to go ahead and cause the incident because it's too much to, have that tension and not knowing when it's going to happen. And afterwards, and this isn't always, but afterwards, often there is a honeymoon phase where the abuser has very contrasting behavior. So they're very loving, may by presence say that they're gonna, not ever let that happen again. So there's things like that, and that is part of what influences a victim to stay, is because they believe that person. And if that person doesn't get help, the abuser doesn't get help, then there's, the likelihood that it's gonna stop is very slim. And then it starts back over, unfortunately. Okay. Oh, Allie, I'm so jealous. I forgot to go fill up my coffee. So are there any questions about that so far? No, we good? Okay. Okay. So if we look at the first page here, page 107, and we're looking at anger and violence. So there are some things, there's not a lot of notes on this particular page. There will be more later, but towards the beginning here, it's mostly just kind of making sure that you understand what these different predictive factors are. So when we talk about these predictive factors, what I want you to understand is that these are things that predict that violence may, happen at any moment, or that they may be getting ready to happen. So if the person has that very angry, irritable affect, if they're very hyperactive, that's one of the most important ones. So if they're up around and they're pacing and they're showing those signs of tension and not being able to sit still, that's an issue. Increased anxiety and tension. And the tension, you can sometimes see people will actually walk around and they'll ball their fists up, and they don't necessarily recognize that they're doing it, but they just look more tense. You can see the tenseness in their shoulders and their back, and you can see those hands getting balled up beside them. The verbal abuse, for sure. Loud voice or very soft voice, making it so other people have to strain to hear you, and you can see that tension in their jaw even. Okay. Intense eye contact or avoidant eye contact. So you either see it where, and maybe you felt this way before, you're so angry at somebody you can't even look at them at that moment. So they could have that avoidant eye contact, or they can have that intense, just kind of glaring at you. And those are all things that we need to be watchful of, because that means that somebody may be ready to act out. Now, there's some other things that kind of go along with violence. So recent act of violence, if somebody's had a recent act, then you might think that they may be violent again in the future. If they're extremely silent, just that stone silence where, when you say that stone silence, you really want to think again about kind of some of that tension in their face and stuff. Suspicious or paranoid thinking, unfortunately, when people are very suspicious of others or they're very paranoid about their safety, they're more likely to be violent because they think that they're protecting themselves. Alcohol or drug intoxication, for sure. Remember that some of those medications like PCP and, some of those actually did make people belligerent and violent. Possession of a weapon, of course, and then characteristics that in the milieu that are conducive to violence. So you need to think about your milieu. Are you seeing that it's very loud? Is it overcrowded? Is the staff very inexperienced or very, very controlling of what the patients do? Do we have poor limit setting and inconsistencies in that? So all of those things are conducive to really upsetting patients and triggering some violent episodes. Now, when we talk about stages of violence, we want to make sure that, we kind of understand what types of things should happen at what stage. And so if we're looking at a pre-assaultive stage, so this is before an incident occurs, then this is where we want to intervene, right? Whenever we have the opportunity to intervene in a pre-assaultive stage, the better off we're going to be. And so we need to make sure that we're calm, that we are in control of the situation, that we speak softly and in a non-judgmental manner. You've probably been in an argument with somebody before, and if you start to get a little bit louder, then they get a little bit louder, and back and forth. So we need to make sure that we speak not absurdly quiet, but just in a nice, calm, collected tone. Demonstrate genuineness and concern and listen. Even if you can't do something about what the patient wants at the time, we need to make sure that we acknowledge that it's a need and that we genuinely seem concerned about whatever that need may be. So even if it's irrational. So this is where it's helpful to look for some of those themes in communication. You seem very upset right now. Can we sit down and talk about what's going on? Let me see if there's anything I can do to help this situation. So it's things like that. And I've seen this work so well with patients if you can get to them early enough. Now, what happens is we then can move on to the assaultive stage. And unfortunately, this is when an actual incident has taken place. And so this is where we're now actively going to give the patient medication against their will, okay? Seclusion or restraint. So we're going to do those things as needed. Now, if they're in the pre-assaultive stage, can we offer them medication? Absolutely. But if somebody's not assaultive, I can't mandate that they take it, if that makes sense. I can't give them an injection against their will. Once they're assaultive, I can. But I may offer somebody just a PO, anti-anxiety medication or something. I can even offer an injection. I've had patients that know them, they start to get out of hand, that they get assaultive and they end up in restraints and they don't want that. So I just offer them, would you like your IM injection now to try to help you calm down? And they say, yeah. So that's helpful to prevent that assaultive stage. The post-assaultive stage, so this is after it happens. And of course, we want to do our critical incident stress debriefing, which is what we do on the staff side of things. But we also want to debrief with that patient. We want to make sure that we're talking to them about what triggered it and what might have gone, how could things have gone differently so it didn't happen? And ask them what are some things that maybe we didn't do that we could have done. And so it's really important that once the patient is actually like calmed down and together, their minds together, then we can ask them what they would suggest and come up with a plan that way. So other techniques we use with our patients, you have to ensure your safety first. If you're not safe, you're not going to be able to protect anybody else. So you want to make sure that you're safe. You want to make sure that you have enough staff and other, staff personnel. You always want to make sure you have an exit strategy. So anytime you're with a patient, and really this is a safety technique for anytime you're with a patient, especially alone, you should always have a direct route to the door. You should never allow the patient be between you and your door. Okay. So you should know where your panic buttons are. I know some places, Flower, we wear a panic button, and then there's also panic buttons on the walls in different areas, and so you should always know where those are. VA, I think they have them at the walls. I don't know that you wear them on the unit. And then the last part of ensuring your safety, I would say here, that's not in the notes exactly, is to always trust your instincts. If you have a gut reaction that tells you that something isn't right, it may not be right. So you need to ensure that you feel safe. So when we have incidents or when somebody is really starting to um, escalate, we want to make sure that we have enough staff to show strength, but only one person should talk to them. Usually it's the nurse, not always. It depends on the experience level of the staff and how they work together. But you only want one person talking and giving directions. Otherwise, it's too confusing to somebody who's escalated. We always want to give the patient the opportunity to voluntarily walk to the quiet room or to their bedroom, depends on where we're taking them, but we don't want to touch them unless we are ready for a restraint episode. Okay. Once you touch the patient, that can take things from I guess it wouldn't be at 0, but from 7 to 10 really fast. So they can start to fight you and all kinds of things. And so you really want to make sure that you're ready for that restraint episode if you're going to have to physically take the person to another room. You always have a predetermined plan with the staff so that you can work together. And so we went through the nonviolent crisis intervention training. And so what we would do when we had an incident is they would say, okay, you're going to take the right side, you're going to take the left side, you're going to get the restraints ready, and so each person, I would get the medication or whatever, and another person would be in charge of talking. And so everybody kind of had their different roles. Set limits appropriately by making sure they are necessary and have realistic and enforceable consequences of exceeding the limits. So we need to make sure that we're consistent. Consistency is extremely important there, and that we're polite but firm. So we need to be polite but firm. So you've not been able to control your actions, so we are going to have to control those for you. Or if you don't get your actions under control right now, we're going to have to help you with that. And so that means that you may get some medication, you may have to go to the quiet room, and so you're polite, but it's firm and there's no room for question there. Again, we want to, whenever possible, give that patient some space. If we start to get too close to them, that can escalate people very quickly. Have your exit strategy. We should try to always be at least their arm's length away. Okay, and it's their arm's length for a reason, right? When someone's escalating, provide feedback about what you observe. So you seem very upset. I noticed that you're really clenching your fists a lot. Can you tell me what's going on? Or can you tell me what you're feeling right now? So we reduce their anxiety by remaining calm, trying to distract the patient. So sometimes our patients are very distractible, depending on what diagnosis they have. We use that to our advantage. If someone is verbally abusive, we don't allow that. That's not something that we just take and let it be. But we can leave the situation and tell them we'll return when they're able to talk to us in a more appropriate manner. Also, if somebody is very verbally abusive, we want to make sure we give attention to them when they are communicating appropriately. So when they come up and they actually ask you for something and they're polite, we need to try to pay attention to that. So that's just, positive reinforcement. And we can schedule contacts with the patient when they are non-abusive. So if you have somebody who starts to get agitated or irritated and rude and mean, instead we can just say, okay, I'll meet with you once every 2 hours and we can see how things are going. We'll have 5 minutes. And as long as you remain non-abusive, we'll continue that. Or maybe it's every 4 hours, whatever you decide. So documentation, it is very important that when we have incidents, and I know we talked about this a little bit already, but when you have an incident, that you ensure that everything is documented, that you know what led up to any sort of incident, that's in the chart, the things that you tried before giving medication or before restraints or seclusion, that if there is a restraint or seclusion episode, or you have to hold the patient down to give them medication, you need to make sure that you also document how many people were involved in that and what type of staff. So if security was up there, that they were involved in it. So it's important that every aspect of it is documented. And you want to ensure, what's actually very helpful from a legal standpoint when documenting, is that you have one primary person who's doing all the majority of the documentation, and then other people who document on the same situation can provide their perspective, but leave their perspective on exactly what they were involved in, but refer back to the main person's documentation. That way you don't have a bunch of conflicting documentation, because that looks really bad in court but people do see things differently. So if we at least refer back to the main documentation, that will help. Psychotherapy. So in general, people can go through anger management type of treatment, and that is something that a lot of patients do find very helpful, to go through some of that anger management. And I've seen patients on the units talk about their anger management and explain some of the process that they go through, and use those techniques when they're on the unit and they're upset. So that is a helpful one. Then the medication. So the medications that we usually use, an atypical antipsychotic, IM, okay? So you kind of have that group of those that have acute IM injections, so not your depot type injections, but the acute ones. And then your haloperidol, that is one of the main ones that are used when somebody is violent. And it can be used in pretty much any age range. And then your benzodiazepines. So an IM injection of those, and sometimes they do add a few of those together into the same injection, just so you're aware. Are there any questions about general anger, violence? No, I'm seeing a few head shake no. Okay. Okay. So now if we go and we move on to the next page, which would be 109, partner and elder abuse. We want to talk a little bit about, the fact that a nurse is obviously a mandated reporter for elder abuse. Intimate partner violence is a little bit different, though. It varies from state to state, because it's considered, adults, and adults they're not vulnerable populations per se, so they can determine if they want to report things or not in most cases. Now, in some states, and actually on the video, you'll get to see them talk about it. The state can actually become the one that puts, I can't think of the right words, but the state can actually come in and say that they're going to prosecute, okay, even without the victim, if that makes sense. Okay, so partner and elder abuse, the nurse can help prevent, detect, and intervene. So abuse can take multiple forms. It can be emotional, physical, sexual abuse, neglect. And then when we talk about our older adults, we also talk about exploitation, which is financial abuse. So the theory that there's interactions of social, cultural, and psychological factors. So when we talk about social learning theory, what we see here is role modeling, identification, and basically that's how people learn about their human interactions. So what this means is that it's children can see this role modeled in their home. They identify with either the abuser or the victim, and then they learn that that's acceptable. They learn that violence is acceptable. It's a reaction to stress, and they internalize it as normal. So they may, and again, it's usually the male against female. So if there's little girls in there, they could see that, well, if I screw things up, then you get hit. And that shows, if another man looks at you, then, you get abused, and that shows love. And so that's how, part of the thought that's how this transpires, and it can go generationally. So then that little girl grows up, and what does she look for in someone? Well, someone who's maybe possessive, controlling, abusive. So societal and cultural factors. So we do tend to see it more when there's a lot of poverty, unemployment, when there's community with inadequate resources, overcrowding. You see a lot of social isolation in families. The social isolation in families is kind of interesting because you don't know if that's more of a, not really a causative factor, but is it that families are isolated and then abuse can tend to happen there? Or is it that the abuse causes the isolation, and the abuser may cut people off from that victim? So can kind of go either way with that one too. You see that frustration leads to aggression, and we also see it more in societies where women are viewed as property and are subordinate in public and private. So women are viewed as property and subordinate in public and private. There's psychological factors. So the abusers will often report that it happens from a loss of control, but it's not shown in their behaviors because they still decide who they're going to hit and where they're going to hit the person. And the video talks about this a little bit too, that, they're not hitting a police officer, right? They're not hitting their boss. They're coming home and they're holding that aggression in. They're controlling that aggression until they get with their partner. We also tend to see low self-esteem, poor problem solving, history of impulsive behaviors, hypersensitivity, so very, sensitive to any sort of criticism, and and self-centered. Okay. So when we talk specifically about intimate partner violence, this is when you have a current or former emotional, psychological, physical, or sexual abuse between current or former partners of an intimate relationship, regardless of gender or marital status. And unfortunately, it's the number one reason for emergency department visits by women. So an abusive relationship is about instilling fear and wanting to have power and control in the relationship. So that's why we see the anger, the physical and sexual abuse, as well as the psychological violence. And the psychological part plays such a role in this It's often how it starts out, and it is what kind of sets everything up so that the abuse can take place. So characteristics of intimate partner violence. So you have the battered partner who is in terror. They live in terror of that next beating. They're often the subject of jealousy and isolation. So because of this, they have feelings of powerlessness, low self-esteem after that constant belittling and insults. They get to the point where they believe that what is said about them is true. So then that isolation, they're isolated from family members, from friends. They're intimidated because they know if they try anything, they could get hurt. They economically often do not have any resources because all of those things are controlled. And they then feel like they have very little power. So you have to stop and think, how would you feel if you were told every day that you were no good, that you didn't matter? So there's all of those that nobody could love you. And so they're told these things constantly. You can never survive without me. And they get to the point where they believe that. The batterer wants to control others. Again, what helps me be a little bit more compassionate, I think it's difficult to be compassionate with people sometimes, but what helps me is to remember that they were likely beaten as a child or witnessed parental beatings a lot. So it's not that they didn't have their own, they have their own issues too. And they may have this sense of loss of control in one's life. They generally have a low frustration tolerance. They often have no guilt or concern, but they can appear well adjusted to the outside. So be very surprised to find out sometimes you think that, families get along really well and everything seems well adjusted, and then it's not until you really get to know, the people are very good at hiding it. Let's put it that way. So they tend to be very possessive, believe in male supremacy. They may have alcohol or drug problems, which can be used as an excuse then. And then there's this subpopulation of batterers, and it always gives me chills whenever I talk about this. It's not in your book anymore, but it was in an older version of the book. And it talked about research that they did on batterers. And there's this subgroup of batterers, they call them a type 1 violent person. So if you can think about if you were in a fight with somebody, okay, or somebody really just pisses you off and you're just angry to the point where you're ready to act out. Think about your vital signs, right? Your vital signs would be way up, your heart's racing, you got adrenaline pumping, right? Where there's a subgroup of people that when they batter, it decreases their vital signs. It calms them. Yeah, which is totally, it literally gives me the chills every time I say it. So they actually have a decrease in heart rate. These are people that tend to have what we call antisocial personality disorder, and we'll talk about that next week. But these are usually people that frequent prison, okay? And as you can imagine, those people do not respond well to any sort of intervention because the violence has its own reward. Okay.
What did you say?
A type 1 violent person is what they called them in this study.
Thank you.
You're welcome. So when we talk about why abused partners stay, they may fear that they or their child will be killed if they try to leave, or if they're found. They lack finances, they lack support, independence. They can have depression, low self-esteem, or maybe even believe that they deserved it, that whatever they did, they earned those punishments. So nursing process, the assessment usually takes place in an emergency department or maybe a physician's office. So some of the things that we look for: does the injury match the explanation? Are there wounds, bruises, even fractures in different stages of healing? We always do our best to try to assess this person alone without the partner. And so this can actually be kind of difficult. We usually, what you can do is you can actually take them to the restroom and say you need a urine sample, whether you do or not, because it can be very difficult to separate them from the abuser or potential abuser in this case. And so they'll follow them to X-ray or CT, they'll just go everywhere with them, but it's really weird for them to go into the bathroom with this person. So that's usually a place where you can get them kind of separated. We want to ask, do you feel safe in your current relationship? Are there children that are being hurt? Diagnosis and outcome. So this patient would be at a risk for injury, risk for violence. And remember, this is such a hard thing to think about, but you have to remember that when you're planning, that it is up to the abused person to make the decision to stay or to leave. It's not up to us. I can believe I know exactly what this person should do, but in the end, it isn't my decision. And that can be a really humbling thing sometimes. We need to be supportive of the person's decision, and we help them make a safety plan. So if they're choosing to stay, then we help them with a safety plan as much as possible. Remember that the person does not usually choose to leave right then, and that he or she makes their own decisions. When we do implementation, we help the person understand that no one deserves to be beaten. She cannot make someone hurt her. It's not her fault or his fault. She cannot make someone hurt her. We obtain consent for photos. So photos usually require their own consent, and we do want to have pictures of the injuries. We ensure privacy. We want to assess for any suicidal or even homicidal ideations. And then any chemical use, so any drug use or alcohol use. We do want to make sure, just like we will talk about with sexual assault, that we do want to make sure that they know that even if they did use a chemical or alcohol, that it still doesn't make it okay that it happens. Okay, it doesn't make it their fault. We ask about any sexual abuse. We want to encourage the person to talk about the incident without interruption. So we want to let them know kind of what's going on, or we want to know what's going on, so we let them just kind of go without interruption, just similarly to like grief episodes and things. We want to make sure that we link them to resources in the community and the ability to press charges. It's important that we help them develop a code word, and the code word can be given to family and to friends, so that they know. So if somebody calls and checks on them, if they say that code word, then that means call the police or I need help. Letting neighbors know that if you hear something, go ahead and call the police. So that somebody's intervening. And we want them to have a bag packed with emergency items, documents that they would need for them and their family. If they have money, a set of keys, whatever they can do to try to have a bag packed and keep it hidden near a door, so that they can hopefully grab it and get out as fast as possible when they are ready to leave. And then of course we always want to give them a hotline number to call. So that would be specific to where you're at, and you want that to be on a very small card, so something they can hide easily from the abuser. We're going to talk just briefly about elder abuse. So this is any physical, psychological, financial exploitation, neglect, or sexual abuse. And often the sexual abuse is not believed. There is a term, it's called granny dumping, where people just leave the older person in the ER. So they take them to the ER for assistance and then just leave them there. Just sad. So characteristics of elder abuse, the abused person tends to be, they need to be over 60 to be elder abuse, but they're at high risk the older they are, so those especially over 80. Caucasian, chronic illness, they're a greater risk for sexual abuse that is disbelieved, which I mentioned. Women often suffer more abuse or neglect, and they often live with a family member. Okay, so living with a family member puts them at risk. The abuser is often under a lot of caretaker stress. Again, they're a family member, they're caring for a family member. And other characteristics are very similar to intimate partner violence. So what's interesting is sometimes you can see this generationally, that they were abused at the hands of this older person, their parent, and now they're abusing them because that's how they learned how to deal with stress, and if somebody isn't listening or doing what they're supposed to do, whatever it may be. So they're really sad situations sometimes. And then adult protective services, I mean, it's anybody who is unable to take care of themselves. So it is those older adults, but it could also be those with intellectual disability, or any other thing that would deem them unable to care for themselves. Okay. Nursing process, we are, and it really shouldn't be usually, we are mandated to report. So we are mandated reporters. We look for things like fear of being alone with the caretaker, malnutrition, bed sores. So this is where neglect is most common. We need to look for those signs. Begging for food, being very passive, withdrawn, emotionless, missing valuables, bruises, fractures, inappropriate dress for the weather. So that's why, in your mental status exams, it asks you, are they dressed appropriately for the weather? That tells you a little bit about their mental status, but also their care. Are they begging? Do they have lots of fractures? Now, I do want you to be a little bit careful. It's always better to err on the side of caution here, but I do remember, like, my grandmother having fingerprints on her arm, and it was because she almost fell, and somebody kind of grabbed her, and she bruised really easily. So it looked like somebody had, like, grabbed a hold of her arms and kind of did something like that, but it was actually because she was getting ready to fall. So you just make sure, if you find bruises and particular patterns and things like that, we're assessing for that, but that you also ask about what the explanation is. And sometimes the explanation makes sense, and you're not seeing the fear, you're not seeing, some of those other indications. So, but if you ever question, it's always better to err on reporting than not. When we look at diagnosis and outcomes, so risk for injury, anxiety, fear, and of course, we're always addressing those immediate physical needs first. Implementation, we want to try to meet with other family members if possible. So I can tell you, we had a patient one time who, an older adult on the geriatric unit, and we thought that she was psychotic. She kept talking about people breaking into her house. And I think she was early Alzheimer's, so we weren't really sure exactly what was going on with her. But she kept talking about how people were stealing her stuff, and her stuff was missing all the time. And here we thought that she wasn't making any sense. We talked to, she lived with like 2 children, adult children. We talked to the other adult children and find out that those 2 are big into drugs and were selling off her stuff. So her stuff was coming up missing. And because they were doing exploitation, they were selling off her stuff for drugs and things, and we would never have known that without the other family members. We want to make sure they have community resources. So sometimes, if the primary reason for the abuse is the caregiver role strain, then let's try to take some of that strain off of this, off the family. We need to work with adult protective services, and they can arrange for housing, medical services. They'll coordinate services, advocate for the patient, and then help with legal interventions as needed. And evaluation overall, is the person safe and cared for? And we should do this as part of a multidisciplinary team. So again, we're not always the direct ones who are calling adult protective services or reporting it. It may be social work or somebody else that is doing that. We just need to ensure that it does take place. Okay, are we doing okay? We have one more. Do we want to take a quick break, or are we doing all right? So shake your head yes for break. No if you're good. See a couple no's.
I have a question really quick. So you know how you were saying that I might have misunderstood this. So you said that like if we find out that like a person is being abused, like that we can help them, like tell them, give them a hotline number, have a bag packed, whatever.
You're talking about an adult, not somebody who falls under APS. Okay.
So are you saying that like we send them back home with that abuser, like, and don't report it if they don't want us to?
Depends on your state.
Okay.
Depends on where you're at and what the law says. But we can't really mandate that somebody files a police report or anything.
Okay.
So we offer it up and definitely tell them that we can call the police. Hey, Jules, you work in the ER, right? What do you guys do if you have an intimate partner violence? Do you automatically call the police, or is it up to the patient in Michigan?
Michigan, the state can sue the abuser. So we're mandatory reporters. So we still call the police. The police come, and then the victim can either talk to the cops or not talk to the cops.
Okay. So
But
you
then
report it either way, and then they have the choice of what they want to do.
Mm-hmm. But the state will still go after the abuser.
Okay.
So it's not really up to the person anymore.
And that's what the video that I have, it takes place in Michigan. So it's all people, it's made by social work and nursing association and stuff in Michigan. So, and it says the same thing.
Okay, that's cool. Thank you.
Yep, thank you. Thank you both. Okay, so we're going to talk a little bit about sexual violence. Again, it's not a fun topic, but it's extremely important that we understand that there are, that you have a role in this. So prevalence and comorbidity, it is often underreported. And of course, it goes along with things like depression, anxiety, suicide, eating disorders, self-destructive behaviors. And usually what we mean by that is very risky behaviors or even parasuicidal type behaviors, substance abuse, trauma, and then people can have STIs, so sexually transmitted infections. I have STDs on here somewhere. They call them STIs more. HIV, and even pregnancy. So victims, they can be either gender. They can, again, it's often not reported. It can be more of an incidence of dominance and control. So usually more than even sexual gratification, it's about dominance and control over the victim. Unfortunately, those less than 12 are at risk. Older adults, those with cognitive impairments, those who are using chemicals, those in poverty, those with high-risk sexual behaviors. So that would mean prostitution. And often you'll see, so less than 12 is at high risk, but 12 to 18 is high risk as well. Cultural considerations, so it can often happen in cultures with male superiority or sexual entitlement. So unfortunately, that's why there's been, military we've seen, fraternities you sometimes see. Nursing process assessment, do not leave this patient alone. They are not stable, no matter how they appear. We don't want that person to be alone. We document the circumstances of the event, gather data. So we try to put as much of it in the patient's words as possible. Have signed consent for pictures again. We would obtain cultures and forensic data. Now, a SANE nurse, a sexual assault nurse examiner, is who is going to do the majority of this. Depending on where you are, but I know for us, I worked as a tech in an ER right next to BGSU, unfortunately, and I mean, unfortunately, there were sexual assaults that happened on the regular from the campus, from the bars, and we always had a SANE nurse on call, so we would make sure the person's not alone. Then we would call in the SANE nurse, and they would do the examinations, work with the ER doctor, and then gather all the evidence. And then we'll talk about the chain of custody and stuff like that too. So they would also have an advocate that would come. So if it was somebody from the campus that was sexually assaulted, then they had a sexual assault patient advocate from the college, and that would help that person. So that was really helpful too. We want to make sure that we document using appropriate language, and I have that a little bit later. Patient's own words. Describe all behaviors in writing. So you want to describe their behaviors, but make sure it's factual. It's not your interpretation of their behavior. Listen. We want to make sure that we determine drug use by the assailant and the survivor, but emphasize that either way, it's not the survivor's fault. So even if they were highly intoxicated, that still doesn't give anybody the right to assault them. We want to identify their situational support. Okay, their situational support. And drug testing. So tests for GHB, Rohypnol, ketamine, and follow the chain of custody. So if you're not familiar with that, basically what that means is that you have to sign a paper that goes along with any forensic data. So when I worked in the ER, it was all paper. There was a paper that would go with, and so if I'm taking cultures over, urine specimen over, that would end up being data, forensic data, then or evidence, then I had to sign that I was holding it, and I'd have to physically give that specimen to somebody in the lab. So I'd have to we only had one lab person. So I have to find that lab person. They'd have to sign the paper, and then I could give it over to them. And sometimes it went, to the police or wherever. So somebody has to be in charge of it at all times. Diagnoses. So nursing diagnosis, there is one that is rape trauma syndrome. And so that's what would be most appropriate in these cases. So you can see acute cognitive, affective, and behavioral disruptions. They can have shock and numbness. They can be in disbelief, have problems concentrating and problem solving. Problems making decisions, and this is absolutely not the time that anybody should be making any major decisions in their life. They can be crying or hysterical or smiling. Okay, the way that somebody reacts to sexual assault is very individualized, so we don't want to be, judgmental. We need to make sure that we understand that part of that shock and disbelief can kind of cause them to have that a potential full range of emotions there. Long term, the patients can often have PTSD symptoms. They can go through re-experiencing the trauma, which is awful. They can be socially withdrawn, have those avoidant behaviors that we often see with PTSD. That physiological arousal, meaning kind of that startle response and that hypervigilance. And they can end up with fears and phobias. Implementation, we want to follow the sexual assault protocol in the emergency department manual. So the emergency department usually has those protocols. And then other places, if there's a sexual assault that happens elsewhere in the hospital, they should be able to get access to that. We want to check for and treat any physical injuries, STI, pregnancy prophylaxis. Again, we collect all of that forensic evidence, ensure that the patient gets hooked up with counseling. We're non-judgmental, help them understand it's not their fault and that it is confidential. They get tested for HIV and STIs. So it's important that they're tested right then. And so the reason for that is so that they can say that they don't currently have it. And if they end up testing positive for it later, there's more evidence to show that they may have gotten it from that sexual assault. And stress that the person did the right thing to save their life. So people may do things that they did not want to do. Maybe they didn't fight back because they feared they'd get killed. And so you have to let people know that you did what you needed to do in that moment to save your life. There's pharmacological therapy, so you can imagine the patient might need a benzodiazepine to help them calm down. So they might need PO, IM, something right there in the moment. And then they may need more long-term antidepressants. They definitely need sexually transmitted infection and pregnancy prophylaxis. You can't require that they take the pregnancy prophylaxis, but it should always be offered. And a tetanus. Unfortunately, these sexual assaults often happen in, on the ground. They get lots of cuts and scrapes and things, and so we do want to make sure they're up to date on their tetanus. Psychotherapy, there's crisis counseling. They should be reassessed 24 to 48 hours afterwards. A lot of times the same nurse will help ensure that these things all take place. And community-based support groups, so we can ensure that they are set up. Documentation, so there are specific words, and your textbook does have these in there, that it's not alleged. We don't use the term alleged, we use the term reported. We don't use the term refused, but declines, and I tend to do that in all my charting anyway. We don't use the term intercourse, we use the term penetration with the sexual assault. And we don't want to chart no acute distress. So if you see a patient who's sitting calmly with their eyes closed, we don't report that the person's in no acute distress, because I don't know that they're not, just because they're sitting there in a pure calm. So instead I can put, patient sitting with hands folded on lap, eyes closed. Okay, so you want to make it very factual, describe their behavior. Evaluation overall, are they relatively free of PTSD type symptoms? And are they close to that, that pre-crisis level of functioning? And then there's a little piece here, it's not on your notes, but there's room for it. I just want to talk to you slightly about human trafficking. This is something that has been added in to what needs to be discussed. And you'll have to do training on it as well in the state of Michigan. But we need, as a nurse, we need to be familiar with signs of human trafficking and how we can help. So once again, we can give an information card to the person, something small, if we think that they may be the victim of human trafficking. It looks a lot like intimate partner violence, okay? Because they often have somebody with them who's very controlling about everything that they do. So we watch for that controlling person who doesn't leave the victim alone. They may even speak for the patient. They might carry the patient's their money or their ID, so the patient doesn't have access to those things. So we watch for stuff like that. And another one is certain types of tattoos. So a tattoo that indicates that they're property or says something like daddy on them, those can be indications of human trafficking. And we're talking primarily here human trafficking for sexual purposes. Just be aware that there's also human trafficking for other types of things as well. Okay, what I would like to do right now is take about, looks like about 8 minutes, so 5 after 10, and I'm gonna watch the video. You don't have to watch the video if you don't want, but I do think it's really helpful. It reinforces the things that we've just talked about today and kind of puts patient faces to it. So I do encourage you to watch it. Might have turned your volume up. I'm using a different computer and things to try to run this, so you have to bear with me slightly.